حياهم الله. طيب، بسم الله الرحمن الرحيم، الحمد لله والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته للجميع، حياكم الله جميعا. First of all, I would like to thank all of the attendees and especially the participants with us in our webinar. So on behalf of our Saudi Ophthalmology Society board, we are welcoming our panelists, and I know most of you know them, and just to make them always more to give them the introduction and they deserve for the attendees from outside. Our first panelist, Dr. Sabah Jastaniya. She is a well-known teacher for most of us. She's a chairperson of ophthalmology department and senior academic consultant, cornea anterior segment refractive surgery in a specialized medical center hospital, and adjunct professor in Al Faisal University. Welcome, Dr. Sabah. And also we have Dr. Musa Al-Harbi. He's a senior consultant ophthalmologist, cornea and cataract refractive surgery and uveitis. He is working now in eye consultant center in Jeddah, and he was also with even Dr. Sabah in King Khalid Eye Specialist Hospital. And last panelist we have Dr. Tariq Mdayan. He is assistant professor in National Guard University. He is a consultant of ophthalmology, and welcome, Dr. Tariq. So our webinar will be focused for a case-based discussion. We have 3 different cases. The 3 different cases have 15 minutes, and you have the QA. You can ask us up, and you will not and inshallah hope all of you think all the specialty and all the level.
Thank you, Saad, for discussing the case with the. I will start with a brief introduction before 3% of myopia in the US. Intraocular lens and refractive lens. Start with the refractive surgery, promising laser and the use of mitomycin C. Also, higher order aberration and regression are changes in hyperopia corneal refractive surgery. Moreover, incidence of epithelial ingrowth is greater with hyperopic LASIK because of the peripheral ablation that is adjacent to the edge of the flap. Proposed mechanisms for the regression include loss of accommodation spasm, mechanical instability of the corneal biomechanics, stromal hyperplasia, and irregular epithelial remodeling, which is a major issue in hyperopic PRK. Several approaches have been proposed to improve the hyperopic laser, which includes applying new advancement in the laser delivery platform and adjustment of the nomogram, increasing the optical zone, blend zone, and the size of the flap, altering the centration of the ablation treatment, and the use of wavefront technology. So which one is better, LASIK or PRK? In 2012, Cochrane review was done to compare PRK versus LASIK, and they could not reach a reliable conclusion, and it was stated that both have comparable efficacy. In this retrospective study, LASIK group showed earlier stability of the refraction in comparison to early myopic shift with the PRK group. At 6 months, both are the same. What's the second option? The second option is the phakic IOL. Phakic IOL offers several advantages as it can address higher range of refractive error with a minimum induction of higher order aberration and faster visual recovery. Also, it's predictable, reversible, and less incidence of dry eye. It shares the disadvantages of any intraocular surgeries such as corneal decompensation, glaucoma, cataract, retinal detachment, uveitis, and endophthalmitis. Now this is the case. A 21-year-old male, medically free, no family history of keratoconus. His uncorrected visual acuity in the right eye 2050 and the left eye 2025. His refraction in both eyes plus 3.5 and cycloplegic refraction plus 5 in both eyes. His best corrected visual acuity is 2025 and 2020. His examination was unremarkable. This is pentacam of the right eye. His K1 is 41.4, K2 42.7, cornea thickness is 570 micron, AC depth is more than 3 millimeter. This is the Bellin-Ambrosio enhanced ectasia display. And for the left eye, K1 is 42.2, K2 is 42.6, cornea thickness is 565, AC depth is more than 3 millimeter. And this is his Bellin-Ambrosio enhanced ectasia display. And endothelial cell count was okay. So now the question, how do we proceed with this case? Shall we go for corneal refractive surgery, PRK or Lasik, or phakic intraocular lens? Can I ask Dr. Tariq al-Madayan? Or Dr. Musa al-Harbi?
Yes.
Or Dr. Sabah? Yes, Tariq. Yes.
First of all, I'm so delighted to join the group. Thank you for the presentation. Very interesting case. Actually, hyperopia is a quite challenge in the refractive field. I'm sure the expert and the panelist will add a lot for this discussion. However, first of all, Ahmed and the rest of the audience, we need, the examination is quite very crucial in hyperopic patient. First of all, the manifest and cycloplegic refraction should be very close to each other, less than 1 diopter. Some experts say less than 0.75. I notice here that it is, if you can go back to the slide, it's 1.5, isn't it?
Yeah, yes, it's 1.5. We will reach that question
And
about the manifest and cycloplegic refraction. Yes.
Because we need to fix this before we choose our option. You got my point. In addition to that, the amblyopic eye, what seems to be an amblyopic eye, is the lesser hyperopia, isn't it?
Both are the same. Both are the same, plus 3.5, but the vision in the right eye is less. Yes.
Yeah, and the less hyperopic eye. So there is a trick here. You got my point. What I would do in this case, I would try to approximate the manifest and the cycloplegic refraction. They should be closer to each other. There are two methods. We need to give the patient higher plus with the 20/20, okay, until he gets adapted to it. After 2 months, I can add until I reach the maximum. You got my point? Because maybe the amplitude of accommodation is large in this patient. This is why his accommodation, the difference is quite large. I wouldn't intervene with the 1.5 gap between manifest and cycloplegic.
Okay, great. Dr. Musa al-Harbi, do you have an added point regarding which option is best for the patient, of hyperopic patient? Your opinion. وعليكم السلام.
طبعا الهايبروبيك in general hyperopic treatment is very challenging comparing to the other refractive errors. And it's not easy actually. Even the satisfaction for the patient and for the doctor will be not that much optimum. So such patient we need to dig more in history regarding when the wearing the glasses, if there is any amblyopia, if there is any esodiffusion or exudiffusion, this is very important. In such this case, there is no big difference between the latent hyperopia and the manifest and the latent. The difference is 1.5, as Dr. Tariq mentioned. We need it less than that. So just we need to make sure if this patient's wearing glasses since long time or no. So if just he wear the glasses soon, that means we need time until we reach the maximum hyperopic correction for the patient, then we can depend on that. In such case, it's very important hyperopia. We need to look for the angle kappa. Such patient with hyperopia usually they have the large angle kappa, so it makes the corrective decision limited. As in this case, we might go back to the topography. So the manifest refraction, you said the 3.5 and the cycler refraction is 5.
Correct.
Usually in such, there is no, around 1.5 the difference. So usually I take in the middle way between both. Maximum 4.5. This is the maximum I can treat. Otherwise, not be suitable to go for laser vision correction. So also depending on the steep case here, for example, here I think 42.7. So every 1 diameter of hyperopic correction will make the cornea steepen by 1.25 roughly. So that means if we correct around 4 in such case, or 3.5, 3.75, that means we will multiply it by 1.27, we'll end up by 5 diameter roughly, or 5.5.
Yes.
If we'll add it to the maximum K here is 42.7, that means we'll end up by 47.5. The limitation depend. Some physicians they said 48, some 49, but I think I will not exceed 48. Still, so we have a space for laser vision correction in such case. But the angle kappa here, if you can label
it is large. It is large.
Yes. Too large. It's it's around 1,000 micrometer, which is very large. So that means we need to take this in consideration during the surgery. That means we need to make our LASIK flap larger, maybe decentered a bit nasally to cover our optical correction, because in such cases usually we need to make it 6.5 to 7 millimeter optical zone. That means we'll hit our edge. So you'll end up by another complications and spherical aberration coma. So we have to keep it in mind. And also you need to calculate the angle kappa. In such case, maybe you make it pupil offset and some machines, and you need to become in the middle, or some machines they might calculate it. So it's not easy, and you need to manipulate it very well intraoperatively, and you need to explain to the patient. Regarding the left eye, I think the angle kappa is fine. Regarding the ICL has a room in such case because of the AC depth is fine. But as we know, the ICL, it's a bit thicker in hyperopia, and those patients might induce actually endothelial loss and glaucoma. So we need to keep it in mind. If there is for me a room for femto laser, I will go for femto laser rather than the intraocular. ICL. Regarding clear lens extraction, it's not suitable if I need to go for multifocal IOLs and right eye by any means, because the angle kappa is more than 400. And we need the opinion now for our senior, Dr. Sabah.
Dr. Sabah.
السلام عليكم جميعا. أنا بس بدي أسألك، أنت تبغانا نعطيك خيارات بعدين حتقول لنا how did you manage the case so we further discuss ولا
if you have this case in the clinic, which option do you choose? Which one? And what are the considerations you take?
طيب أول شيء بالنسبة للpresentation, if I may speak, أنت you presented it very nicely but as a case of myopia not hyperopia. بمعنى إنه you were concentrating على موضوع إنه ما في family history of keratoconus. وريتنا الشارت المختصة يعني you were into this أكثر من إنك وريتنا الأشياء اللي تهمنا كهايبروبيك correction كpresentation. من ضمنها زي ما ذكروا الدكتور موسى والدكتور طارق موضوع الأنجل كابا، موضوع الديامتر اللي نقدر نروح له، how much are the case expected to be steepening ولا لا، وهكذا. The second thing, we need to ask this 21-year-old male patient why he wants the LASIK. Is it just for getting rid of his glasses? Is it just to improve the reading without glasses ولا for military job مثلا؟ لأنه هذه حتختلف شوية معانا in regards to the decision. Otherwise, he is fit for ICL لأنه ال AC depth is fine, everything is fine من هذه الناحية. بس الأنجل كابا يمكن تكون هي الإشو. He is reasonably fit كمان for LASIK. So after discussing with the patient and seeing which way he wants to go, and for me, I would go for femto LASIK. To choosing the femto LASIK لازم أختار طبعا corneal ablation يكون wider زي ما ذكر. بس PRK is not my favorite for hyperopia anymore. The ring that it forms, the scar, even if you use mitomycin C, and we have seen cases ما نقدر نقارن our patients to patients من studies done في US وفي Europe لأنه we've seen more scarring, much more scarring. يعني الآن هم سمعت إنه البعض حتى بيسوي PRK without mitomycin C. إحنا we cannot do this in my opinion because we see scarring even with mitomycin C. So this ring and the issue of continuous steepening post-treatment should be in mind. وبالتالي, if I would go, I would go, my first option would be LASIK. طبعا we take care of this integration مرة مهم. The LASIK is my choice لأنه فعلا it gives much better outcome للpatients عن ال PRK.
Okay, Dr. Sabah, if you are faced with manifest refraction plus 3.5 and cycloplegic refraction plus 5, and you are going for femto LASIK, do you go or you will wait?
No, I will go actually.
Yes.
Yeah, I will go. حيحدني شغلتين. الشغلة الأولى الكيس، أنا أشوف إيش الماكسيمم كيس اللي أنا I can reach it and I go يعني under this case. فمثلا لو أنا I can treat 4.5 I would go for 4.5. صح في الإيشو حق induced اللي هو حق accommodation and we may have induced myopia, but most of the people, if they understand it well and you explained it well, they will overcome it within the next few weeks after surgery. And you go slowly. If you have time, you can تزود النظارة المقاس حقها and you can see later on how it goes. بس I will go with the 4.5 or whatever I can go إذا الكيس حتسمح لي فيها.
Yeah, more with a cycloplegic refraction. Okay, thank you so much. I found this interesting retrospective study on 186 hyperopic LASIK. They found that increasing the preoperative difference, manifest cylinder difference, the post-operative achieved spherical equivalent showed undercorrection and hyperopic regression. The author recommend treating the manifest spherical equivalent if the difference is less than 1 diopter. If it is more than 1 diopter, they will take the mean. Refractive lens exchange is not an option in this case because of its low hyperopia. I found this review article by George Alio. They mentioned the situation in which refractive lens exchange is indicated, and these include when the lens starts to lose its accommodation, and when there is a risk of higher order aberration if the laser vision correction is attempted, and in patients with high hyperopia who are unable to wear glasses or contact lens due to their systemic condition. Several studies showed satisfactory refractive result in the treatment of hyperopia with refractive lens exchange. RD and cystoid macular edema are lower than myopic refractive lens exchange, but bear in mind that in short globe, the refractive lens exchange carries a high risk of choroidal effusion, suprachoroidal hemorrhage, and inaccurate IOL calculation. With this slide, I conclude my talk, and thank you so much for your input.
Can I just add one thing?
Yes, please.
Thank you for this case. Interesting. فيها a lot of things to learn عموما. لو جاتك هذه الكيس مع hyperopic astigmatism، يعني let's assume this is plus 3.5 minus 2. It's a straightforward case ما في keratoconus. Do you think the treatment would be better ولا the ablation will be worse?
I think it will be more complicated with the astigmatism, hyperopic correction and astigmatism.
Any opinion?
What do you think?
لا تكون easier لأنه أنت في النهاية as the machine takes the spherical equivalent فيها حتى ال treatment it takes about few seconds less than if it was hyperopic treatment alone.
I see.
Can I add something, Ahmed?
Yes, please.
أولا يعطيك العافية. Thank you so much. Very nice topic and very nice presentation. There is actually one article that is very valuable in regards to hyperopic treatment. It's in the British Journal of Ophthalmology. Not very, maybe 2019 or 18, I can't recall very well. However, they have mentioned the high hyperopic patient from +3 to +6. They did PRK, okay? Now, what is the problem of hyperopia? Predictability and stability. They have regression, okay? So first of all, as mentioned by my colleagues, chair time is crucial. You scare the patient. You do not only inform him, you scare him. Tell him about regression, high chance of regression. If he accepts, you proceed, okay? You really should exclude high demanding patient from hyperopic patient treatment. Now, what are the causes of the problem, if I may say? First, corneal issues or lenticular issues. I guess the lenticular issue is dependent on your assessment pre-op mainly, okay? So your skill in approximating between the manifest and cycloplegic is the key factor for this. As much as you keep them closer to each other, the better the results, okay? Because with age, the amplitude of accommodation is lesser and the latent hyperopia will manifest, okay? In general, the older the patient, you go closer to the cycloplegic refraction. Now, in regards to regression, the first, I read about this topic because it's quite controversial. The first few years, like 3 to 4 years, usually regression is caused by corneal remodeling. After that, it's lenticular problem, okay? So this study in the British Journal of Ophthalmology, they mentioned that having large optical zone up to 10 millimeters, they reported much less regression compared with Lasik, because Lasik is limited by the size of the flap, and smaller PRKs. They showed the reports, they compared it to other comparable articles. They found that the regression is less by half. They claim to be because of the large optical zone. Okay, this is regarding surface or corneal treatment. Just one little note for hyperopic ICL. I want to remind everyone that there is no aqua port, no central hole in hyperopic. So we go like the older version. We should do PI. Okay, it's not like the current ICL. And it is thicker, as mentioned by Dr. Musa and Dr. Sabah. Thicker, so be more careful about it. Thank you.
Thank you so much, Dr. Tariq. Thank you so much, Dr. Ahmed. I give Dr. Ahmed more time because he's starting the first one. So he's lucky, but we'll move to the second case with Dr. Abdul Hamid. Dr. Abdul Hamid, he is fellow in Prince Sultan Military Medical City, and he is one of our brother from Bahrain. You can start, Abdul Hamid. The floor is yours.
Thank you, Dr. Saad. Thank you for the invitation. Assalamu alaikum, everybody. Good evening. I want to thank the Saudi Ophthalmology Society for this opportunity. And today I would like to share with you a challenging case that we faced recently at PSMMC under the care of Dr. Anud Saad. The case is a 33-year-old male patient with history of renal transplant. He underwent renal transplant in his early 20s due to renal failure caused by focal segmental glomerulosclerosis. He's been on systemic immunosuppression in the form of tacrolimus and steroids since then. So when he presented to us in December 2019, he presented with steroid-induced posterior subcapsular cataracts with best corrected visual acuity of 636 in the right eye and 624 in the left eye. The patient was a pharmacist. He was well educated, and he actually has done his research and read all about the multifocal technology, and he actually came seeking a multifocal IOL implantation. So after long discussion and ensuring his motivation for spectacle freedom, and he made it clear that his priority is freedom of glasses while reading and for distance as well. So while finding no contraindication, he underwent an eventful sequential phacoemulsification with toric multifocal IOL in the right eye and non-toric multifocal IOL in the left eye. The IOL choice at the time was fine vision by Physiol, which is a diffractive IOL. The first month post-operatively actually was uneventful. He tapered steroid slowly over a period of 1 month, and his vision improved by the end of the first month was at around 6.9 at distance, and with excellent vision at intermediate distance and at near vision. He was spectacle free at that time. However, 6 weeks post-operatively, he presented with 1 week history of deterioration of vision, which was much worse in the right eye than the left eye. And the best corrected visual acuity at that time was 660 in the right eye and 624 in the left eye. The anterior segment examination, apart from a clear cornea, quiet AC, and a normal intraocular pressure, the slit lamp examination actually showed significant fibrosis of the anterior capsule with a shrinkage of the capsulorhexis size down to 2 by 4 millimeter almost, and with minimal decentration of the multifocal IOL in the left eye, and a much more significant decentration superiorly of the right eye multifocal IOL. It might not be very visible in the video, but the center of the multifocal IOL actually was under the fibrotic capsule here. So with this presentation, and initially I would like maybe to direct a question to if any of the panelists would like to give us an idea what would be the initial more reasonable first step in such a case with the severe capsular phimosis, given that one eye has a multifocal IOL and the left eye, which is minimally phimotic, has a multifocal IOL. If any of the panelists would like to give us an idea.
Thank you, Dr. Abdul Hamid. Nice case. This was a challenging case from the beginning to implant a multifocal IOL, and especially considering that this patient is on steroids and they may develop other retinal complications later on that will compromise the vision. But if we take that aside, having phimosis reasonably, if discovered as you did early, is very good to do an anterior capsulotomy, laser YAG anterior capsulotomy, just tiny, maybe 4 or 5 cuts in the rim of the anterior capsule, and then reevaluate if you need to do more. I had a similar case like this with the multifocal IOL, and with the multifocal IOL, but it was not toric. And after the cuts, he did reasonably well. Everything kind of slowly went back to normal. Then he recovered his vision almost but not completely as perfect as it was when it was first implanted.
Great, thanks a lot, Dr. Sabah. As Dr. Sabah mentioned, the management for anterior capsular phimosis, even in monofocal IOL, will be mainly non-surgical using the YAG laser or surgical intervention in severe cases where we have to surgically dissect the dense fibrotic anterior capsule from the IOL. And more recently, some 2 German papers published a use of the femtosecond laser to assist in creating those anterior capsulotomy, as Dr. Sabah mentioned, and with good success as well. So in our case, this is what we started with. We did go for in the YAG laser anterior radial capsulotomies. And actually for the left eye, this was very helpful. After only 2 radial cuts nasally and temporally, the IOL popped back into place and the haptics sort of unfolded. And at 1 week, as you can see in this picture, the IOL was well centered and the patient was much better symptomatically. However, for the right eye, after doing multiple YAG, actually maybe around 4 in this area and this area and 2 more here, despite enlarging the biomotic capsular excess size, the IOL is was still decentered superiorly, as you can see here, and the haptics were deformed and distorted and folded over the optic and pushing the whole IOL backward, causing a hyperobic shift as well. So at this stage, let's say maybe I would direct the second question to the panelists. What would be a reasonable next step? Would you further do another attempt of YAG laser? Would you go straight away to IOL explantation, exchange with a monofocal, or maybe try to fix the same IOL? What would be a reasonable next step at this stage?
So this is a monofocal, isn't it?
This is a toric.
Toric monofocal.
Multifocal.
Still multifocal. Still, if there is a chance to add more YAG before final destination, which is maybe a removal of the IOL. So I will try to give another trial of YAG if possible. Keeping in mind and just talking and counseling the patient at the end of the game might need to change it. This is very important.
Can I add how long you waited after you did the YAG?
I think around 2 weeks maximum, not more than that. Actually, the patient was very annoyed. He would visit us routinely. He needed some quick solution.
And there was no improvement at all after the first YAG?
No, not after that picture was taken. Actually, it was taken from the intro of video, but 1 week after the first YAG, no change at all. Later on, we also, with full dilatation, noticed that even the axis of the IOL has moved from the intended 160 degrees to even more horizontal. So we were more worried also about the axis alignment at that time.
For me, actually, if I feel satisfied with my first trial of YAG, if I think I did my best and I can't do any more, I'll go for surgery. I'll make monofocal IOL standby in cases of a problem of the capsule happens, because with severe capsular phimosis, sometimes the zonules are broken. So, but first, intra-op, I will try to release, to cut edges of the anterior capsule, to release it. If I'm successful, well and good. If the IOL, I feel it is centered and the axis is better, well and good, keep it as it is. If I feel that it is compromised, I would put the monofocal. Before the surgery, you explain with the patient all the possibilities.
Great. Thanks a lot, doctors, for your contribution. Actually, we did go for surgical intervention eventually, which raised another question whether to use the same lens or try remove it, replace it with a monofocal, as doctors mentioned. The patient was very clear when we are having the discussion that his priority is spectacle freedom, and he wants to try to, as he said, save the lens as much as we can. So keeping that in mind, we did consent the patient for the possibility of exchanging it with a monofocal, like Dr. Tariq said, and we went ahead for surgical intervention. This is one of the reasons why the YAG, maybe we're a bit conservative with the YAG capsulotomy, because we're trying to make sure that we don't harm the bag in case we're going to go later for surgical intervention. We need the bag intact. So the surgical intervention, actually, Dr. Anud Saati decided to do a modification to the 4-flange proline IOL fixation technique described by Sergio Canabrava from Brazil, and in an attempt to reposition the lens, first to ensure axis alignment. Our idea was having 4 points of fixation holding the IOL in place could ensure at least the axis alignment if we can manage it properly. And if we can achieve centration and IOL axis alignment with this procedure, there will be no need to exchange the IOL at least and give the patient the best possible outcome. So after, as you can see in the video, introducing the iOS hooks. So as Dr. Tariq said, first we tried to release the contraction using viscoelastic from under the fibrotic capsule, but it wouldn't, the IOL wouldn't nudge. You can see some folds at the back showing how much of tension the bag was under due to that capsule. So at the 160 axis, after marking it, 4 capsule sclerotomy marks were marked equidistant from the 160 axis, and the 5-0 proline suture was used. First, we tried that it passes easily in a 27 gauge needle, and then from an opposite paracentesis, the proline thread was introduced, and the 27 gauge needle was passed from the first sclerotomy mark under the first haptic, and the 5-0 proline thread was fed in the needle, externalized, and the other end of the thread was fed in the 27 gauge needle from the other side of the haptic as well, and also externalized. This process was repeated on the other side of the IOL, and then trimming of this suture was done, and cautery. Now this first step ensured that since we have the entries equidistant from the axis, we ensured that when we pull these threads, we'll have the IOL in the desired axis. But later on, after releasing the lens from the fibrotic anterior capsule even more, make sure that it unfolds naturally, then we can adjust the centration. As you can see, the centration needs some adjustment temporally. So after cutting the fibrotic tissue and releasing the lens from this phimosis, the IOL was the threads were further trimmed and cauterized as necessary. And wound was finally hydrated, and intracameral ciprofloxacin also. So these are the post-operative picture. As you can see, the proline hubs under the conjunctiva here, and the IOL gained. We achieved good centration. You can see here the vision did improve significantly with the patient from 660 to 636. However, at 1 week post-operatively, despite being on 1 hourly topical steroid for the first 3 days, then 2 hourly for the rest of the week, we did notice he had a significant fibrinous AC reaction with the flare. We didn't want to risk the IOL developing any pigmentation or having a problem with the IOL, so we injected him with intracameral TPA, and at 1 month after this injection, his vision improved to 636 plus, but this time with significant posterior capsular opacity. So posterior capsulotomy was done, and finally at 3 months, he is 610 partial. The vision is 610 partial. The patient is actually driving and is spectacle free at all distances. However, he's still not very satisfied with the quality of vision, despite the IOL position, which was reasonably well. I mean, with the minus 0.25 and 0.25 cylinder on the auto refraction, the IOL position is considered acceptable. So it's been 3 months since the second procedure. Should we blame this on neuroadaptation failure yet, or should we give the patient more time? This is maybe the final question for discussion with the panelists. At what stage would you consider a patient to be a case of neuroadaptation failure? Is it 3 months enough? Would you give them more time? And if so, if the patient, you consider him a neuroadaptation failure, would you go for exchange with a monofocal, or like some new trends, exchanging it with a different technology of multifocal IOL, or maybe go with extended depth of focus, for example, with a mini monovision, for example? What would be the best preferred, maybe?
First of all, just I want to say this is not a usual case. And because of Dr. Anoud, she's so talented, mashallah, and very skillful surgeon, she could manage this case. But actually, this case First of all, from the start, as Dr. Sabah mentioned, this case is not suitable for premium trifocal IOLs, as this patient has a lot of multiple system problem, and he might get retinal diseases. And also, as you mentioned in the history, this patient is high demanding. So from the start, once the complication started, you need to actually to counsel the patient that I think the best is to go for monofocal IOLs in such case. Entering the eye multiple times, because this patient, I mean, the premium IOLs, it needs standardization during the surgery. The scleral fixation is not that much suitable. It can be done, but it's not that much suitable for the premium IOLs. And the neuroadaptation, you cannot guarantee the neuroadaptation to be achieved. Multiple entry might cause macular edema, as those patients prone for retinal diseases, diabetes also. So the patient will not be happy maybe at the end of the day. So such entering, I think I would just go for the simple way to go for monofocal IOL from the start, explantation, and I need to just counsel the patient. I hope also that this flange will not be with time degraded and or moved, and that I will moved, and the patient you need to go back to take the lens. In regular cases, I would wait up to 6 months for the neuroadaptation. After that, I would re-evaluate the patient, and I will see what's going on. Sabah, you have any add?
It's a beautiful surgery, صراحة. It's enjoyable when you see it from all aspects, mashallah. The thing is, I just want to mention one point to the fellows and whoever is listening to us. Don't be pressured by the timing the patient sets for you. This is a very important thing. This is a trap that makes us take bad decisions that we regret maybe for the rest of the management of this patient or the rest of our lives. And I know, and all of our colleagues have seen those cases where they pushed us into doing something, and then you will never forget this case. It will just keep on the back of your mind, and it will keep. I'm sure Dr. Abdul Hamidi will never forget this case as well. So the 2 weeks time period was not enough, in my opinion. You could have waited a little bit more for 2 reasons. First of all, you could have tried a little bit with the YAG and see how it would go. The second reason, which is the most important reason, is to make the patient understand how significant is entering again, and how dangerous is entering again, and how reluctant you're going to do that. So I would just, take it longer, step by step, until maybe a month or 2 passes, as long as the capsular phimosis is under control and the YAG is working well. Now, during the if I'm going for surgery, certainly I would go and change that lens to a monofocal lens, because I have a second element of toricity here. But as long as the surgery is done, and as I mentioned, it's beautiful surgery, alhamdulillah, without any complication, then I would not fall into the same trap the patient sets for us in doing the retreatment or the exchange early on. I would give it a chance of 6 months, give lubricants, try to make sure that he is not closing one eye and examining each eye alone. And take him step by step through the neuroadaptation process until it happens. Of course, this is after making sure that the access is correct. Thank you, Doctor.
For me,
Well, 1 minute.
your question was for how long I would wait before I intervene. Maybe 3 to 6 months. I would go like 3 to 4 months, because you don't want to wait for a longer time. The IOL might be adherent to the capsule, especially that he reacted more than usual. He developed fibrinous reaction. Actually, this point should be investigated. He's taking systemic tacrolimus and things, and he developed this inflammation. Maybe we should look into that. Second thing, the type of IOL, I would put monofocal, of course. Thank you.
His reaction would make me think twice before going early, actually, because he has aggressive inflammation, so you don't want things to go out of it when going early.
Especially he done systemic anti-inflammatory tacrolimus.
Yeah, it's weird that he's developing this.
Hamid, can you conclude, please, if you have anything?
Yes, actually, I'm concluding just with my take-home messages. Multifocal IOL technology, as the panelists have said earlier, it's a complicated technology. It needs careful patient selection. And even when you control the patient's expectations, you have to be ready to deal with any surprises as they arise. And you have to give the multifocal IOL patient time before the surgery in the form of chair time and after the surgery for new adaptation. And finally, several intrascleral IOL fixation techniques have been described recently, and some of them shorten the time of the classical scleral fixation IOLs from the usual 45-50 minutes procedure to even 15 minutes in some cases. So utilizing and having good knowledge of these techniques can be very helpful when you're dealing even with when you have to reposition at work or multifocal IOL. It can be done to a certain acceptable results in most cases. And thank you all for the time and for your opportunity.
Thank you so much, Dr. Abdul Hamid. It's a nice case, and thanks for Dr. Saadi for picking up this interesting case and for the, mashallah, the skillful surgery. We'll go now for the last last case we have with Dr. Umar Al-Hadlag. Dr. Umar Al-Hadlag is a fellow in King Saud University. So the floor is yours, and I want to remind there is a short presentation at the end of after the case of Dr. Umar from our sponsor, the company Santen. Go ahead, floor is yours, Dr. Umar.
Thank you, Dr. Saad. Good evening, all. I would like to start by thanking Saudi Ophthalmology Society for arranging this webinar, and thank you for this opportunity. Microbial keratitis is a very controversial topic, though the main guidelines and management may be clear, but gray lines are plenty, and you may find different management approaches by different treating physicians. Which is why I would like to present this case and take the panelist's opinion. My patient is a 68-year-old diabetic patient, known case for decompensated cornea in the right eye post-cataract surgery, and was on the Bedford for BID for a long time. Came to our ER suddenly with pain and redness for 3 days in that eye. Seen elsewhere, stopped his Bedford and given Vigamox Q2 hours, then came to us for 3 days later with this picture. A semi-ring infiltrate and an area of thinning superior temporally. The infiltrate is almost at the limbus border. So we managed by admission, scraping, PCR, and fortified antibiotics, vancomycin and doxycycline for the thinning. Retinal span was observed, and we added oral moxifloxacin. We followed this patient, and on day 2, unfortunately, I don't have pictures for that, but the stains were negative on day 2, cultures are still not out, and PCR was negative. The patient symptomatically was worse, pain is more, and on examination, infiltrate got more dense and advanced more toward the limbus. So I'd like to ask the opinion of the panelists. What would you change in the management in general? Let's say, for example, would you rescrape or change the antibiotics or use other modalities of treatment like intrastromal, subconjunctival injections or cross-linking or surgical intervention?
Just want to ask you, Amar, what do you think, what's the disposing factors in such case?
Sorry, again?
What do you think, what's the predisposing factors in such case? Old patient, acidic bullous keratopathy. So,
yeah, and he was also on steroid. He most likely was having some ruptured pulleys. So there was risk of MK in general. So patient was not left alone, but there was no history of trauma or contact lens used during this attack. No other risk factor other than the steroid use, honestly, and the pseudophakic bullous keratopathy. This is what's most important in this patient. I don't want to present the whole history because just to shorten the case.
Okay, just I need you to keep two issues in your mind in such elderly patient with such chronic diseases that they might sometimes, and we forget it in the history, because they are using the drops a lot. So they might hit their eyes by the drops itself. And even the contamination in such drops and how they are preserving it. So there is a chance for fungal keratitis in such cases. Although those patients are a little immunocompromised, and so we have to keep atypical microbial keratitis in mind. This is just we need to treat, as you mentioned, by standard way until we are not reaching the diagnosis, and we will see if there is any progression. If there is an improvement, that means we are on good track. If there is an deterioration, that means we need further investigation.
دكتور كان أقدر أسألك how many days you have been treating him with Vanco and Sefta?
From our side, this is 48 hours, but he was also on Vigamox 3 days before coming. So in total, let's say this is a 5th day of MK now.
Yeah, but this is the second day of proper treatment. So in this case,
48 hours.
In this case, I would just maybe observe, and if the next day is the same, then I would take another specimen. One important question in the history, I would like to ask the occupation of this patient or where he lives.
He's actually retired and he's living in Al Qasim.
Okay, so he around farm or anything? We're just
no, he was living at home.
Bear in mind one thing. Fungal keratitis is in the mind of all of us. However, once you start it now, say that you start the antifungal, and you only just started Vanco and Sefta yesterday, and the patient did not improve, you will be lost because you don't know what is it because of. Is it the antibiotic or the antifungal? So you will lose the track. I wouldn't rush to change, to shift him to antifungal unless there is something like threatening, for example, reach the limbus or something like this. In addition to that, confocal might be of use here, confocal.
Yes, actually, all of these points are very important, as you mentioned. Thank you all. Also, for the patient, as the patient was on steroid, and the shape of the infiltrate, especially some of multifocality or feathery edges, we were thinking of fungal, and in the first scraping we sent for also calcifier staining and special stains just to make sure that there is no fungal. Unfortunately, all came negative in matter of staining. From our side, we were really bothered by this limbal reaching. So, and this worsening, we wanted to make sure that we don't reach, the infiltrate does not reach the limbus. So our management was, we re-scraped at that day and also redone the PCR. We decided to do intrastroma and subconjunctival injection of antibiotics, Vanco and Sefta. Also at that time, retina planned to do tap and inject. And we added a topical antiviral because on examination, we noticed that there is decrease of corneal sensation, and with that edema, we were just making sure there is no risk of hepatic on top of that. So I would like to ask the panelists now, if I can, would you prefer intrastromal injections in such a case over other modalities, or do you have a criteria to go for it?
And for me, it's too early to go for intrastromal injections in this case.
You need to reach the diagnosis first.
Yeah, you need to reach to confirm the diagnosis. You need to give the patient some time, because you never know, even though he mentioned that he started on Vegamox, you never know about the compliance. You never know if he used it properly or not. So in this case, it's really early in 48 hours to rush for any conclusion.
Okay. So this is a patient on day 4. He's symptomatically much better, reduced pain. First cultures are still negative. Second cultures preliminary negative. All stains also have been negative. On examination, as you can see, the thinning has improved. The infiltrate, especially superiorly and nasally, have scarred. The inferior quadrant was still active and dense. The hypopyon started to contract. So at this point, would you do any changes in the management? What's your goal in the management at this point? As you can see, this is the current management that the patient was on.
Doctor, can you go back to the previous slide, day 2?
Okay, sure. Actually, this is day 1, not day 2, because day 2 I couldn't find any photos.
Now, can you go back to day 4?
Sure.
For me, this is melting. I can see the filtrate, but I see a lot of melting around it. I'm not sure if you consider this as improvement. Of course, here I cannot see what you really clinically saw, but I would be considerate about melting in this case. And one thing, as was mentioned by Dr. Tariq, now you don't know, is it because of the antiviral or because you gave the subconj injection? The improvement, if you consider, if you're considering this as an improvement now.
Clinically, there was no melting. There was no necrotic tissue. There was no thinning. Actually, the area of thinning improved. It reduced in matter of thinning. Maybe it's not very clear in this picture, but it is clinically, it shows clear scarring in that area rather than necrosis.
Who is the epithelium on top of it?
The epithelium is still a CED.
Umar, can you go back to the previous photo?
Sure.
Actually, which I could see the central dense yellowish infiltrate.
This one?
Yes, become and the other, I mean the 4th day, a bit settle down, much better for me in the color. And it's not increasing in size, but actually the area above it, as Dr. Salah mentioned, I mean, it's a suspicious, yes, it's a suspicious area. There is any melting there or no? I mean, the slit lamp examination is very important, actually.
Unfortunately, okay.
Regarding the hypobian, actually, we are not depending on hypobian per se, although it seems to be increased here.
It was, I don't have right now, I picked a slim photo for this to show you how the cornea thickness is fine. And the hypopion actually is contracted. Maybe the photos are not very clear from your side or from this compared to the slit-lamp examination. And maybe I'm biased because I'm the one who managed the patient. But I'll just go on with now. Our plan was we were now happy with the improvement. Still, the patient is in active infiltrate as the dense area that Dr. Musa was mentioning, that it's better, but it's still active. So we continued on the fortified as is. We also gave another trial of intrastromal, focusing on that area to hit it harder. And we shifted from the topical antiviral to oral antiviral to start the patient on reducing the amount of toxicity that he's receiving. And on day 9, as you can see here, he finished the full course of oral moxifloxacin, all cultures are still negative. Examination showing scarring of the infiltrate. Even the inferior part is now much settled and mainly scarred rather than active infiltrate. There is no clear active area. CED is, if you compare it to previous, is getting smaller and smaller. This case actually diagnosis was made clinically as a mixed bacterial and herpetic corneal ulcer. And we started tapering the antibiotics, followed by a trial of Bradford cautiously, and we added lubricant drops and inserted BCL to improve the bacterial defect. So I'd like to ask another question for the panels of the modality of their epithelial management. What's their, let's say, what's your preferred goal in such a case, or preferred modality? Would you go for AMT, tarsorrhaphy, mega contact lens, Procaro, or only topical drops, and so on?
First of all, actually, beta herpetic, it's one of the differential diagnosis actually, but the one against is the age of the patient. Usually it comes earlier. There is usually other signs of herpetic keratitis like blood vessels and these things. Still, I'm in favor of microbial keratitis. I mean, either bacterial or atypical, or we should keep fungal. But while we are seeing there is an improvement, that means fungal become a little away. But atypical microbial keratitis should keep it in mind. Actually, before the question regarding the even decreased corneal sensation in older patients, it's not an pathognomonic for herpetic disease. So still, to confirm it, you need, I think, biopsy in such case. If you need to confirm it, I have to exclude other microbial, bacterial, or fungal keratitis. Then you might label the patient as a herpetic, because you need to keep him for long time on antiviral therapy. And he's an old patient, maybe he has some renal impairment, and you need to keep it in mind. Until complete healing, I mean, the recovery of the microbial keratitis, and there is a persistent epithelial defect, we might go for amniotic membrane transplantation.
بالنسبة لي reaching this result within 9 days, this is an extraordinary, this is very good result. السيدي ملحوق عليها، خلها بعدين، عرفت؟ الآن with excessive lubrication, with maybe with debridement of the edges of the ulcer, and only maybe later بعد على الأقل أسبوعين 3 if not improving, maybe contact lens, it will improve. حاليا في الوقت الحالي الريزلت that you've reached in 9th day is amazing, fantastic. Wait with tapering of the antibiotics, the fortified, وهذه الأمور, thing will improve. We will consider all these options only later بعد ما خلاص أتأكد there's no more infection, more quiet. I might add FML to suppress the inflammation. طبعا debridement of the edges, هذه we can do it early. Actually, as Dr. Musa mentioned, it's part of the enhanced penetration of the speech antifungal. Forget about CED for now on the 9th day, and continue treating the bacteria, taper antibiotics slowly, and the CED will be managed.
حيفاجئك الدكتور. He will surprise you. I'm sure he have done something on day 9. He's being on the rush of treating this case so early. Am I correct, Dr. Amar?
Well, actually, what I'm saying in day 9, and maybe you misunderstood me, this picture is showing on day 9 how much of improvement we reached by this modality of treatment, topical plus intrastromal 2 times. So if we can even I'm not sure, maybe the pictures are not very clear again, but most of the activity of the infection is gone. It's mainly, as Dr. Abdullah was usually prefers to call it, it's now at an inflammatory phase. Yet we didn't start directly with prednisolone and the epithelial defect. But what I mentioned is from now on, we started thinking of the inflammation and the epithelial defect because most of the activity has been settled.
Yeah, but you are thinking viral at the same time you want to reduce the inflammation. So, you know, you're doing very well with this case, but if it was me, I would have loved to have, if I'm not certain, to have a biopsy at least. Not for the case of the management, and for this current situation, but just because what Dr. Musa mentioned, if you label this patient as viral, then this will be for the rest of his life. So yes, I would be thinking of how the epithelium heals, but then if this is herpetic, you wouldn't start any kind of steroids early on.
Okay. Actually, we didn't start it early. We only started it around 14th day, after at least almost 11 day or 12 days of antiviral total, full therapeutic dose. And we started very, very minimal, and we trying it cautiously. Then we started increasing it just a little bit. The patient is still healing, and we can see this is on the next follow-ups, then the next follow-up, and this is most recent follow-up. At this point, we decided that Aprocera is a good option for him, and to improve healing more. We're still following the patient. Unfortunately, the CADs did not heal yet, but he's doing much, much better. And if we still have time, I would like to ask some related questions from your experiences.
Yeah, you have one minute, Omar.
Okay, would you consider herpetic as a cause in such a case early on, or would you would like to have a PCR, or just I mean, would you do PCR, or would you diagnose it clinically? And do you do PCR for MK with reduced corneal sensation? I mean, all of them, or we don't even consider PCR?
If I may use just 10 seconds. From the beginning, herpetic is not priority on my list in this case. I think herpetic is not the common that we see in the case of pseudophakic or in case of bullous keratopathy.
Yes.
Decreased sensation is common in these cases with bacterial keratitis or microbial keratitis. So again, it is not conclusive. You cannot rely on only decreased sensation to say this is herpetic, and then manage the whole case as herpetic. So I'm a little bit having a question mark on this diagnosis.
What convinced or increased our suspicion is the early presentation of these blood vessels. Still, that does not say that this is for sure herpetic, and I totally understand. And we did PCR twice, and it was negative. But clinically, he improved after our antiviral more and intrastromal. So that's why we're labeling him as a mixed MK.
Omar.
That's
تفضل.
yeah, sorry. Doing both treatments at the same time for two suspicious diagnoses gives you a confusion of what is the case and which medication did the management part. Dr. Musa Marf.
Yes, actually, as you mentioned, for herpetic, yes, we all know it's some mimicking, or sometimes it can confuse us. But I will not label it until I try to exclude bacterial or fungal keratitis first. Otherwise, as you mentioned, if we label this patient as a herpetic, Although herpetic usually, this is what we are noticing actually, usually it comes in earlier age. It's not mandatory, but usually it comes in earlier age. There is a history of recurrent redness, recurrent inflammation in this eye. Usually there is another associated factors like blood vessels from the start, or glaucoma or uveitis. Still, I might, I mean, if I'm confused in such case, just I will treat as a microbial keratitis, and I will take my time and observe. If I'm in confusion, I will take biopsy. Then after that, I might think of herpetic.
Dr. Omar, may I add something?
Yes.
Actually, do you know why my senior colleagues, Dr. Musa and Sabah, are really irritated by this antiviral thing? We've seen many cases. When things go south, everyone start to give, in addition to the antibiotics, antifungal, then the patient will not improve. They add antiviral. So after a certain point of time, you are lost. You don't really know what's happening. Luckily, and with the skills of you and Dr. Fawaz, this patient was managed well. But it's not uncommon to reach the level where the patient is on many, many medication, and you really lose it. You don't know what's happening anymore. And then you have to stop everything and start all over again. This is why we really want to know what's the pathology so we can treat it and follow it. Okay. And in addition to that, there is an entity called Hertz reaction that I'm sure you know it, that in the first day, with the massive death of the organism in response to your antibiotics, especially with the spirochetes, but also in antibiotics, there is severe inflammation that might lead to melting and more inflammation that give us an impression that the patient is worsening. This is why we say in day one, if the patient is not improving, it's okay. You got my point?
Yes.
This Hertz reaction, we tolerate it. We pass it in the first day until we reach further. And only later, if the patient is not improving, we consider other possibilities. So knowing the diagnosis is more valuable than adding other regime, especially if we are squeezed in the corner where there is almost melting. Of course, there's a lot of gray zone in this. Thank you.
This is also why I mentioned this case.
Dr. Omar, can you conclude, please?
Yes, this is exactly why I mentioned this case, because of the gray zones that it surrounds it from all over. To start with, from the beginning, our main concern was the limbus. If this is really a fungal case and the limbus is reached, actually the patient was kept MPO for the first 4 days until we actually saw this improvement. Because at any time we were thinking of pushing the patient for surgery, either for biopsy or therapeutic PKP, just to prevent this microbe from reaching the sclera. Yes, maybe it's a bit aggressive to start the intrastromal early on, but that was like a measure we had to take just to prevent us from doing further or more damaging, or keep the patient observing him, and the microbe might reach the limbus. At least that's our point of view from
Thank you so much. Thank you so much, Dr. Omar, for the nice case, and thank you all. For the sake of time, I want to introduce our colleague from the Santin company, our sponsor for society activity, and they will have short presentation. And I'm sorry for there is some question. Sorry for that, for the sake of time. But last message I want to say to my colleague and friend from Fellows and Residents, please try to be eager to participate in such webinar, such case presentation. It will give you more with such experts, our teacher. They will give us even, you will learn from each one, especially the time management of case presentation, to break the barrier to present a case. It is not shame. Just go ahead, and time by time you will earn a lot of skills. I'm one of the residents and fellows. I was shying to present and to go and I was always disappearing when someone asking question. The online webinar give us a lot to participate and to develop these skills. So welcome back, Simberghost. The floor is yours for the presentation.
Thank you very much. This is Bassem Barghouth, Middle East Business Manager, Santen. Actually, I am very happy as a Santen to be a part of this nice scientific discussion. It's really interesting. Today, I am very pleased to introduce our medical affair lead, Dr. Pascal. He's responsible about lead central cluster, Middle East, Dutch, and Nordic. Dr. Pascal will take us through a brief discussion about VKC, vernal keratoconjunctivitis, and Santen cationic emulsion technology. Please, Dr. Pascal, please can you start? Doctor?
Right. Okay, sorry, I was still on mute. Thank you so much at the Saudi Ophthalmic Society for the invitation, and I must say a big bravo for your excellent format of case presentations and a very lively discussion, which is, I think, the best format to really learn a lot. I enjoyed it very much. My presentation will be hopefully not too basic, as I see the panel is really eminent corneal specialists, so I will try to be short and just take a quick view into vernal keratoconjunctivitis. Vernal keratoconjunctivitis, or VKC, is one of the most severe forms of allergic conjunctivitis, which involves both the tarsal and the bulbar conjunctiva. All these numbers that you will see on the slides are to be taken very cautiously, because the epidemiological data is very scarce, as this is a very rare disease. The problem with the correct diagnosis is that the symptoms that you will see in VKC patients do very much coincide with the symptoms that you will see for any allergic surface disease. So they are not very specific. However, if you go to the clinical features, then at least the Horner Trantas dots, which I will show some pictures of later, are clearly signs that orient you versus the vernal keratoconjunctivitis. Also, if you see that the symptoms persist for longer time than it should be in normal allergic seasonal conjunctivitis, that gives you already an indication, I should say. Obviously, as you know, vernal keratoconjunctivitis concerns mostly children, declares usually under 10 years of age, and luckily for a large number of these patients, it resolves by itself during puberty. You will have more male than female patients, and the only epidemiological data that I found about Saudi Arabia was actually indicating that in the pediatric ophthalmic unit, it's about 1% of patients. It's really very rare. The prevalence is highest in countries with hot and dry climates, which are clearly linked to the pathophysiology. And it represents a big burden for these children. Obviously, when the eyes are itching, when you experience photophobia, you will not be very likely to enjoy going out, playing sports, meeting friends, and especially anything that is around going swimming. But also the school attendance is clearly impacted. So for the right diagnosis, things that can give you good hints are in the medical history of the patient. You will look at the age of onset, because those patients might take actually several years until they come to the specialist practice. You will look if there's seasonal variation, how long it has been going on, and also if there's a background either in the family or in the given patient of other allergy or atopy. And then obviously you look at the conjunctiva and the cornea, and you don't want to forget to return the lid to look at the tarsal conjunctiva for the cobblestone papillae. Skin tests might be helpful, even though, yeah, the IgE levels were considered not to be suitable, as only 56% of patients are positive, so you might be having a false negative. Obviously, you need to rule out infectious causes. And to do the differential diagnosis, you will probably try to have a look at these clinical features. So here you see two photographs of the typical tarsal form of VKC, usually under the upper lid. And the worse the disease, the bigger the papillae will be. You have giant papillae or even cobblestone papillae. And these are a big problem because of the simple mechanical friction that they put on the cornea. So even if you calm down the situation with steroids or other, you might still have problems of corneal decompensation due to the friction of these giant papillae. Horner Trantis dots present as you can see here, as sort of whitish gelatinous infiltrates at the limbus of the patient. They might be, in rare cases, 360 degrees, but they can also be just in part of the limbus. And these are typical for VKC. So there is the two forms. You have the limbal form, you have the tarsal form, or you may have mixed forms where you have both of these clinical indicators. I don't think I need to go very deep in the corneal complications that you can get. 3 to 11% of patients, again, to be taken cautiously. Apart from the friction that I mentioned before, obviously the actual inflammation that is caused causes also damage to the cornea. And then as a secondary effect in children especially, obviously there's always the risk that you get a microbial infection. Keratitis is present, should be looked for by fluorescent staining. And so we come to the pharmacological therapy. Before you come to the actual pharmacological therapy, it must be made sure that the patient and his parents, his or her parents, understand that the best thing that they can do is to avoid whatever provokes the exacerbations. So if it is the sun, if it is wind, if it is the dryness outside, I know it's hard to tell a kid to stay inside, but this is often one of the best advices that you can give to these patients. In terms of pharmacological treatments, obviously, as in all allergic situations, antihistamines and mast cell stabilizers will be used, but usually they're just not giving the relief that is expected, and that should also give you an indication that this might be VKC. In the end, and this is also to be taken very cautiously, what always brings relief is corticosteroid topical therapy, but obviously for the very well-known complication that these cause, these have to be given very cautiously and also on very short period of times. It has been observed that the relief experienced by the patients has motivated the patients or the parents to abuse corticosteroids, even though they were aware of the complications. So this has to be observed very tightly. The mainstay of the long-term therapy of this chronic condition should be immunomodulators. This is a short animation just to show you what the mode of action is. So vasoconstrictors, which are sometimes used, are purely cosmetic. Actually, they only limit the vasodilation. If you use mast cell stabilizers, you will obviously block all the results of the degranulation of the mast cells. Antihistamines will block a bit more than just the histamines, but also some downstream factors. And the non-steroidal anti-inflammatory drugs, they do block the prostaglandin pathway, but this is certainly not the most important or prominent pathway. So corticosteroids, well, this would be basically a big cross over everything. We just put the cross here over inflammation to say that everything is been blocked. And immunomodulators, especially calcineurin inhibitors, can be used safely for the long term. Now, as you know, calcineurin inhibitors especially are lipophilic, and this is then a challenge for us because it's hard to get it to the ocular surface. It has to go through the tear film. So what we have developed and what you might already know as dry eye treatment under the name of Cationome is a so-called cationic emulsion. You have in this emulsion nano droplets with oil in their core and a phospholipid monolayer around them, which makes them polar on the exterior and apolar and lipophilic in the interior. Additionally, these nanodroplets carry a strong positive charge. And as you know, the glycocalyx on the surface of the epithelium of the cornea carries a negative charge. So when you drop in these drops, they will adhere and spread very well over the ocular surface. If you want to have a look into the future of the treatment, I can advise you to look at the two now published studies about the treatment of vernal keratoconjunctivitis with cyclosporin in cationic emulsion. If you want to get your hands on these publications, please don't hesitate to contact our business manager in your region, Basel. I'm also happy to take any questions. Otherwise, if you want to ask later or via email, you can send it to Basim and he will forward it to me. Thank you very much.
Thank you so much. Thank you, Basil, for the sponsor this webinar. And I want to ask the panelists if they have any comments regarding this presentation or our cases. Otherwise, we can conclude.
Thank you very much.
So thank you so much all for your attendance and your patience on us, and thank you for the presenter, our super fellows. And inshallah, in the next we will have other rounds. So with anterior segment or other specialty in the future with the society. I will remind all of you, the Saudi Ophthalmology Society, it is your society. Please give us your suggestion, contact us, approach us in the Saudi board. So all of us will improve and work hard to develop our society to be in the standard with what we wish and we want. Thank you so much and good night.
Thank you. Thank you. It was really nice. Thank you.